First off, I want to thank all of you for joining us here today for a very, very special School Lunch and Learn presentation. We have alumni tuning in from all over the world. We have guests joining us from 6 different countries, including France, Canada, Hong Kong, Japan, Jamaica, and the United States. Now, before we begin today's presentation, I wish to acknowledge the land in which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now, you're probably wondering, why is today's presentation extra special? Well, today is International Women's Day, which is a global day to celebrate the social, cultural, academic, and political accomplishments of women, and to reflect on the challenges and work that lie ahead. In honor of International Women's Day, our guest speaker is someone who has dedicated her career to applying human factors engineering and leveraging health disparities frameworks to improve equity in healthcare delivery. Her research embodies of International Women's Day this year, which is #EmbraceEquity. To have the power to cultivate true inclusion within our community, we must embrace equity and celebrate diversity. Now, Professor Myrtede Alfred's current research is a fantastic example of U of T's commitment through the Defy Gravity campaign, which aims to dismantle barriers, overcome global health challenges, and create models to achieve health equity, which ultimately aims to improve the lives of future generations. Now, a quick housekeeping item. At the end of today's presentation, we will have time for a formal Q&A. Should you have any questions for our professor, please submit them using the Q&A button below. Now, for individuals who submitted your questions during the registration period, thank you. Thank you for pursuing your curiosities and sharing your insightful questions with us. We have shared your questions with the professor before today's presentation, and we will continue to share them throughout. Now, without further ado, it gives me great pleasure to introduce our MC and chair of the School Lunch and Learn program, Laurie Hevola. Laurie isn't just an electrical 65 graduate. He's also someone who is the most dedicated and engaged members of our alumni community. Laurie has been chairing School Lunch and Learn for almost 10 years now and continues to generously dedicate his time to maintaining our Lunch and Learn traditions. Now, with that, please join me in welcoming Laurie Hevola, who will now introduce our speaker for today's event.
Thank you, Sierra, for your very kind introduction again. It is indeed my pleasure to welcome our guest speaker today, Professor Myrtede Alfred. She is an assistant professor in the Mechanical and Industrial Engineering Department here at the University of Toronto, where she directs the Safety, Equity, and Design Lab, which conducts research on socio-technical factors impacting patient safety and healthcare equity, and develops interventions to improve system safety in clinical environments. Prior to joining the U of T, she spent 3 years conducting patient safety research and applying human factors approaches to improve the delivery of care at a large academic hospital in the United States. She has published over 20 peer-reviewed articles, and her research has been funded by the Agency for Healthcare Research and Quality, the Natural Sciences and Engineering Research Council, and the Canadian Institutes of Health Research. She obtained her PhD in Industrial Engineering from Clemson University in 2017, where she held the Southern Regional Education Board Dissertation Fellowship and Janine Bowen Graduate Fellowship. And now, without further ado, please join me in welcoming our guest speaker, Professor Myrtede Alfred.
Thank you for that wonderful introduction, Laurie. I'll go ahead and share my screen. So, Laurie, if you could just give me a thumbs up, Laurie or Sierra, thumbs up that my screen is viewable.
Looks good.
Perfect. Thank you. So about 20 years ago, the Institute of Medicine in the US released 3 seminal reports about quality of care in the US. And so what these reports, and so that's to err as human, crossing the quality chasm, and then unequal treatment. And so what these reports determined was that there was a greater need for systems approaches and systems analysis in healthcare, and that healthcare needed to be considered as a complex socio-technical system in order to support the design and redesign of healthcare to reduce errors, improve quality of care, and also reduce some of the racial and ethnic disparities that are pervasive in the US. And so that's what I'm going to talk to you about today. So I'd like to start off by thanking the Lunch and Learn team for accommodating my request. I teach at noon, and so they were able to allow me to speak earlier than the normal Lunch and Learn sessions. And so, as Lori mentioned, prior to joining U of T, I spent 3.5 years at an acute medical center, academic facility in the United States, in Charleston, South Carolina, actually, conducting both patient safety research as well as supporting quality improvement. And so in this role, I had the opportunity to sit on the patient safety and quality improvement teams where I used human factors. I was kind of in a consulting role, and I used my human factors expertise to support system redesign efforts at the hospital. And so just to ensure we're on the same page, human factors engineering examines the relationship between humans and systems, the systems with which they interact. And so it's primarily around achieving 3 goals: improving safety, optimizing performance, and increasing satisfaction. And so in that consulting role, I was able to both conduct, as I mentioned, conduct patient safety research, mostly around perioperative safety, but also really work on improving the design and delivery of care. And so in the past 20 years, this integration of human factors professionals and researchers, similar to the role I had at my prior institution in healthcare, has started to increase. And so I've marked just off the top of my head. So if there are human factors colleagues in other countries, forgive me if I haven't noted you, but you can see that there's a lot of integration of human factors professionals supporting quality improvement and patient experience and safety in a range of hospitals across the US as well as in Canada and across the world. And so there's even been a development of an organization, Human Factors Transforming Healthcare, that created this network of researchers and professionals working directly in hospitals or working directly with hospitals. And so my role at the Medical University of South Carolina, my previous institution, really kind of shaped my interests, my research interests in 2 different directions that are related but distinct. And so that's patient safety and clinical systems equity. And those are the two areas of research I'm going to discuss today. And so with my patient safety work, I generally start off with a systems analysis approach. And so this is kind of the macroergonomics for those of you who may be familiar. And so that's trying to get an understanding of the system, how the system is operating, what we call work is done, trying not to make assumptions about how things work in a different clinical system that we're going to be analyzing. And so we do this generally through interviews and observations and some data analysis. And so with that, we tend to build an array of models, including process maps, task analyses, abstraction of hierarchies. We might do axi-map investigations. We might do a failure modes and effects analysis. And so that's just the first part of the research, as well as we do similar processes for quality improvement, where we might also incorporate root cause analysis. And then depending on the project, we might also incorporate cognitive ergonomics, physical ergonomics, in terms of understanding specific research questions within the project. And so this might be looking at decision-making, assessing workload, looking at visual inspection techniques in terms of cognitive ergonomics. In terms of physical ergonomics, we might look at, for example, the overall design of the workspace, the lighting in the environment, noise in the environment. And then generally with our work, and I think the part that's both fun and frustrating, but very important, is using our research to also inform quality improvement opportunities, intervention development, and intervention and implementation. And so I'll give a couple examples of some of the projects that I've worked on. And so I'm grateful to have had the opportunity to work on a number of different projects in healthcare, some more with the QI focus and some with both kind of a QI and a research focus. And some examples include improving the efficiency of our surgical instrument reprocessing process, trying to support coordination in transplant and trauma, improving anesthesia medication safety. And on the slide, you can see one of the interventions that were designed as part of that project. But today I'm going to focus on two projects. One that finished up this year on robotic assisted surgery. Really that project was on advanced technology integration in complex systems. And we use robotic assisted surgery as the case study. And then an ongoing project that I started in the US, but I'm continuing in Canada on retained foreign objects. After going through these projects, then I'll spend the rest of the time focusing on my clinical systems equity work. And so for those of you who are less familiar, robotic assisted surgery is not a fully autonomous robot conducting the surgery, but rather a surgeon who is, as you can see in the image on the bottom right, is sitting at a console and they're controlling a robot at the surgical table, which is allowing them to perform the surgery. And so with this project, we were trying to assess some of the challenges associated with integrating advanced technology, such as the Da Vinci robot, in surgical environments. And we did this by collecting data on what we call flow disruptions, which are natural or unnatural kind of deviations in the progression of surgery or procedures. And so flow disruptions tell us a bit about some of the challenges, the underlying challenges in the systems. And flow disruptions are associated with higher mental workload as well as errors. And so I got to spend a lot of time in operating rooms observing robotic surgeries to collect this flow disruption data through direct observation. And we also assessed workload using the NASA TLX. And so from this analysis, we were able to identify specific challenges related to, for example, the experience of the surgeon. More experienced surgeons are tended to have less flow disruptions, as well as differences in the actual procedures. We tended to look at kind of a lot of gynecologic procedures as well as urology procedures. And so there were differences among procedure types, as well as huge differences created by the size of the room. And so smaller rooms as well as larger rooms tended to have a lot of flow disruptions. And from this analysis, we were able to recommend different interventions around tasks, such as designing robotic surgery checklists in a preoperative briefing. We looked at the workspace and were able to work with actually Intuitive to discuss some room sizes, which would be ideal for the robot. It's difficult to tell in the picture, but the robot is huge. It does take up quite a bit of space in the OR, and there tends to be issues with it hitting the booms, for example. And then we also developed interventions, actually a really neat intervention around teamwork, because one of the challenges we noticed with robotic surgery and in general, when you're integrating technologies, such as the Da Vinci robot in complex environment, you're sometimes going to have these unanticipated consequences, right? And what we saw were the differences in the team dynamics and in the communication needed to support a smooth procedure. And so we ultimately designed an intervention around improving teamwork using escape rooms. The second project that I'm gonna talk about is on retained foreign objects, also known as retained surgical instruments. And so this is when an item such as a sponge or an instrument is unintentionally left in a patient following a surgical procedure. And so retained foreign objects is part of a small group of errors that we call never events. So the idea is that they're so kind of egregious that they should never occur, but of course they do. And so I'm going to do a quick activity. I realize I cannot see everyone on the call, but I'm going to ask a question, and so you can type your answer. You can type your answer in the chat or just say it to yourself. But I'm going to ask you for this example to pretend that you're a radiologist or a physician who's going to be reviewing an X-ray to identify whether or not there's a retained foreign object. And so we're going to do two quick examples. And so I will give you a second for your visual inspection. But do we see a retained foreign object in this image? Okay, so I'm gonna assume that you responded. What about in this image? And so it was a bit of a trick question. Some of you might have figured out that this is actually the same patient, and these are just X-rays that are provided at different angles. And so with this research, the team I'm working with, we're trying to identify some of the causes for for misses, right? What are some of the underlying mechanisms that result in missed retained foreign objects, including on radiographs? And so is it inspection errors, is it detection errors, or are these decision-making errors? Part of this research is also trying to identify whether or not we can develop object detection with machine learning algorithms to support the detection of retained foreign objects in radiographs. And so I'm actually finishing up the proposal to CIHR due tonight at 8 p.m. So wish me luck. This research, actually, I started at MUSC. I started while I was in the States, and I wasn't sure it was an area I would continue when I moved to U of T. But interestingly enough, Canada leads comparable nations in the rate of retained foreign objects. And so you can see it's about 2 times the average of the OECD, other OECD countries. And so that meant that there was similar to in the US, there was an opportunity to improve both the detection and prevention of retained foreign objects in Canadian hospitals. And so I'll spend the rest of my time talking about some of my newer or more recent work on clinical systems equity. And so what this research is looking at is trying to understand how factors specifically in the clinical system contributes to healthcare disparities. And so if you're not familiar with the social determinants of health framework, we all kind of understand that there are social factors that impact our health, right? Different socioeconomic factors, different environmental factors, as well as our own individual behaviors. The social determinants of health model also points out that healthcare is roughly responsible for about 20% of our health outcomes. And so that's, that's not the majority, but that's sizable. And so in addition to trying to understand how we support health at a population level, we also need to think about how we improve the quality of care that's being provided. And so as I mentioned earlier, the 3 reports from the Institute of Medicine, one of them being unequal treatment. And so in this report, they identified over 175 studies that were documenting disparities, not just in terms of health, but in terms of kind of access to health services, as well as quality of care. And so in the US, health disparities are huge and pervasive. And so there's less data, there's less research on health disparities in Canada, but the knowledge base is starting to grow, and most of my work is on maternal health outcomes, and that's one of the areas where we're starting to see growing research. Another important distinction in the unequal treatment report was on the difference between health disparities and healthcare disparities, where health disparities focus on kind of these underlying differences in our health that's really attributable to social determinants of health factors, whereas healthcare disparities are unique to quality of care. And so the unequal treatment report was 20 years ago, but since then we're continuing to see and understand challenges in health disparities. And so we saw an article by Nature that discussed kind of biases in healthcare algorithms. There's long been research on differences in pain management when it comes to healthcare, and particularly Black women in and around pregnancy. A recent study from Brigham and Women's Health Center, the big health center in Boston, I believe, found that Black patients are more likely to face security calls and kind of adverse experiences related to kind of engagement of both security as well as even things like putting essentially handcuffing patients to beds when they're determined to be a threat to themselves and others. And then another big area of research around transplants with Black patients having much lower rates of transplants from everything from liver to kidneys to hearts. And so we see kind of consistently that there are these large disparities, not just in health, but in terms of utilization of health services, treatments that are being offered, as well as overall quality of care. So the unequal treatment report went on to mention something that's kind of really critical to understanding the need for, I think, industrial and human factors engineers in not just in healthcare, but specifically working at the intersection of healthcare and health equity. The most significant gap in this research, which is referring to kind of the disparities research, is the failure to identify mechanisms by which these disparities occur. And so they provide different examples, right? We're looking at patient and providers' attitudes during clinical encounters. We're looking at the nature and quality of communication, clinical decision-making processes, as well as the overall environment and settings in which care is delivered. And so ultimately what the report suggested and research since then has suggested is that health system and hospital level investigation is really going to be a critical and key element of reducing racial and ethnic disparities, not just in the quality of care, but in health outcomes in general. But as you can imagine, there are quite a bit of challenges related to doing this work. One of the big ones, as kind of mentioned by the report, is that there's not a clear causal mechanism when we look at the relationship between the health outcomes in different demographic patient demographics. With the exception, I think, of implicit bias, where we're starting to see more research that directly links, for example, implicit bias to differences in pain management for patients. We don't always understand what is the relationship between some of these healthcare processes in some of these disparate outcomes that we're seeing. Another barrier is around the lack of data. This is more acute in Canada than it is in the US, right? Where you don't always have the demographic data you need to even conduct a disparities or health equity analysis. Similarly, you might have data, but it might not be at the level that's granular enough to support hospital level interventions or support QI initiatives to improve health equity at the hospital level. The third challenge is that even when we have the data, and this tends to be the case in the US, where some data is often available, this data is not regularly disaggregated or stratified by race to facilitate the analysis around potential health disparities in variations in the quality of care. Similarly, the measures that we use are not necessarily always sensitive to identify statistically significant differences in these outcomes. So for example, if you're using mortality and morbidity, which, you know, the values of these for these outcomes might just be too low, too small to really facilitate any statistical analysis. And then there's no real conceptual framework to guide systemic or systematic health equity investigations. And so that's some of the work that's also being done around how do we think about integrating equity into some of our normal and regular patient safety processes and research. And so that's part of what I propose to do with my clinical systems equity work. And so the idea is to complement the socioeconomic models, such as social determinants of health, with some of the what we call kind of socio-technical models, looking at the relationship between people and systems to focus on what is happening within the individual hospitals, what's happening within the health systems that's resulting in disproportionately adverse outcomes for certain patient demographics, right? And so the idea is, how do we apply essentially an equity lens to both patient safety research and patient safety practice? And so one of the interesting dynamics, I think, is that, you know, I mentioned doing both patient safety work and clinical systems equity work. And so as you can imagine, those areas of research are related, but I mentioned them as being distinct. And that's because we don't necessarily always apply an equity lens to our patient safety research or our quality improvement efforts. And so that causes us to one, potentially miss out on different issues that have differential impact for smaller, generally, you know, ethnic minority groups, which make up smaller percentages of the patient population. And so differences in that harm can be hidden. And then alternatively, we might generate interventions that further exacerbate or introduce new disparities if we're not also considering the impact on racial and ethnic minorities. And so with some of the work that I proposed to both the Agency for Healthcare Research as well as INSERC was around trying to think about how we apply this equity lens in some of, our normal kind of human factors and systems analysis research in healthcare. And so what is, when we're thinking about equity, what does that look like when we're examining the current state of the system? What does that look like when we're analyzing processes and outcome? And then also, what does that look like when we're monitoring system performance? And so I want to go through one example. And so I mentioned my research on health equity focuses on maternal health. And I use it as kind of a paradigm of clinical systems and equities for a variety of reasons. One being that in the US where I started this work, maternal mortality was high and actually increased during the COVID-19 pandemic. There were huge and kind of well-documented racial and ethnic disparities in outcome, both at the national level and then, at the for a lot of states as well. Maternal mortality and severe maternal morbidity are largely preventable with timely and risk-appropriate care, which is suggested that there's a big quality of care component to some of the adverse outcomes that we're seeing in maternal health. And then similarly, this was one of the health disparities where the outcomes are less confounded with socioeconomic factors. And so, for example, Black women, even at higher levels of education, higher levels of income, private insurance in the US, still face worse outcomes than the majority population. And so we see there that that made it a bit distinct from some of the other health disparities in the US. And so the other reason I think maternal health is a good case study is that racial and ethnic disparities in maternal mortality are also found across the world, in the UK, in Brazil, in Netherlands, in France, as well as in Canada. And so prior investigation of adverse maternal health outcomes in the US found that 25 systems factors contributed about 25% or 25% of the factors that were associated with poor maternal health outcomes were systems factors. The teams that do this analysis, the maternal mortality review committees, they didn't tend to include human factors expertise. So I tend to believe that number was a bit underestimated. And so for one of the studies that I was funded to do this work in the US, I conducted my initial investigation at a large health system in the Southeast. And this investigation included observations and interviews, as well as the examination of some of our patient safety event report, data from our patient safety event reporting system. For those of you who are not familiar, this is a system in which any hospital employee can voluntarily report some incidents, some adverse events. In this system, they're going to answer a series of questions about what was the impact of the event, what they believe caused the event, and provide a narrative description of the event. And so it's a way to track some of the adverse events that are occurring in hospitals. And so the event reporting system generally does not include, outside of, I think, age or date of birth, it doesn't include other demographic information. And so we use the medical record numbers to connect the data to our clinical data warehouse. Being a large academics research center, it was a very useful resource to have. Smaller hospitals, for example, might have to do this linking process using directly through the charts, which is a kind of a longer, more more effortful process than sending a bunch of medical record numbers to our clinical data warehouse. And so with that, we were able to connect the adverse events to different patient demographic information to facilitate our analysis in a way that we could also disaggregate it by race. And so overall, we conducted 23 observations totaling over 100 hours. And these observations were conducted in labor and delivery. They were conducted in antepartum and postpartum, as well as in the women's health clinic. We also conducted 16 interviews with OB physicians, with anesthesia residents and attendings, nurses, nurse midwives, as well as patient safety coordinators for the women's health department. And so, as I mentioned, we typically always start with the systems analysis. And so on the screen, I'm showing you just kind of a task analysis we perform to understand kind of what the nurses do in labor and delivery, as well as in postpartum and antepartum care. We also conducted, this is similar to an axis map, similar to an abstraction hierarchy, where we start to identify some of the barriers, some of the challenges to safe and equitable maternal care. And so this is an example of some of the task-related factors that we identified both from our observation and interviews. And so this is kind of the general analysis that we might do if this work just focused on patient safety from a general perspective. The difference with kind of the equity lens and the clinical systems analysis is that we started to break this data down by race and ethnicity. And so the hospital had 3 big groups of patients: non-Hispanic white patients, non-Hispanic Black patients, as well as Hispanic patients. I believe non-Hispanic white patients made up something like 57% of the patients, non-Hispanic Black patients somewhere around 32-33%. And then Hispanic patients made up about 9%, and then patients from other demographic backgrounds made up. Actually, when we started the study, less than 1%, but within the kind of a 2-year frame, increased to about 4%. And so we're seeing on the slide the breakdown between the incidents that were reported in 2019 and 2020 for our labor and delivery unit, our mother or baby unit, which includes postpartum and antepartum care, as well as based on race and ethnicity. And so a few things kind of stuck out to me, and is one of the areas that we're investigating a bit further. We see here that in 2019, a lot of events were reported for non-Hispanic Black patients, whereas in 2024 labor and delivery, most of the events were reported for non-Hispanic white patients, which we would expect given kind of the distribution of our patient population. The other thing you might notice is that there are significantly less events reported in 2020 compared to 2019, and we think that was partially due to the COVID-19 pandemic. What we were also able to do was start to look at some of this data statistically, right? And so we wanted to understand, what was the rate of adverse incidents for each demographic. And here we see that, non-Hispanic Black patients did have a slightly higher odds of having a reported adverse event. And so then we looked at differences between years. We looked at differences between methods of delivery. The other data I'll point out, but I didn't highlight, is that you can also see that cesarean sections are greatly associated with higher rates of having a reported adverse events, as well as anesthesia. As anesthesia type. And so in a subsequent analysis, we found that Black patients, for example, were much more likely to have a cesarean delivery, and similarly, Black patients were much more likely to undergo these procedures with general anesthesia as opposed to epidurals, which are considered the gold standard. And so the key findings from this system analysis, which we're writing up, we're actually going to provide as a report to the hospital, is that 8% of the deliveries had a reported incident. And then in terms of our disparities analysis, non-Hispanic Black patients were overrepresented in the incidents that were reported. They had higher rates of cesarean delivery. There were differences in the anesthesia type that should also be investigated. And there were a number of different events for which Black patients were disproportionately represented, and that included anesthesia events, falls, transfusions, and complications of surgery and care. And so for us, this is a starting point to start to understand, okay, so what is it, what's happening in those anesthesia events, what's happening within, what are contributing to higher rates of falls, and what are contributing to higher rates of transfusion. And so the idea is that we've taken our normal analysis process for patient safety events and have added this equity lens to try to understand where different clinical process potentially results in higher burden of risk and disproportionately negative outcomes for different patient populations. For this work, as you can kind of tell, I'm focusing on disparities for non-Hispanic Black for the non-Hispanic Black population, because we're aware that on a national and even on state levels, this is the group that suffers the highest rates of adverse outcomes. And so we're almost actually the grant for this work ends this month. We were able to get a short no cost extension to extend it from the original end date this past September. And so we extended it because we wanted to create some geospatial kind of representations of the distribution of outcomes. So I have one example that's presented on the slide that looks at the prevalence of cesarean delivery according to census tract within Charleston County, where the research was conducted. The other area that this work is being expanded, is on mapping the journey of pregnant and postpartum women to understand their experiences of care. And so that work is being conducted both in the US, and I was actually recently awarded a small seed grant to start this work in Canada as well. So that's going to be a nice and interesting comparative analysis that's going to hopefully start this summer. And so I am happy to take questions.
The first question is an online question. Early in your presentation, you talked about RFOs, and Marv expresses the thought that the control process, according to his understanding, was a count of the equipment going in before and after the operation. Why does this fail, and what new control procedures did you recommend?
So I should mention I'm just starting this work, so it hasn't been conducted just yet, and so I haven't. The team hasn't made any recommendations. But in terms of the count process, counts are, as you can imagine, a critical part of reducing retained foreign objects. But there are two issues. One, in I think 88% of retained foreign objects, the count was marked as being correct. And so that suggests there are different issues with the count itself. Similarly, when counts are incorrect, they still only catch about 54% of objects that are retained in the patient before the patient before the patient is closed. And so we like to describe counts as necessary but insufficient for reducing retained foreign objects. And so I'll just give you an example from some of the work, actually, some of the experiences I had reviewing during my robotic surgery observations. And so sometimes, they count all the instruments at the beginning and the end of the procedure, but I think challenges occur because one, not everything is counted. So hospitals have different policies on what is counted. And secondly, I think one of the big challenges are when new instruments or trays are brought into the procedure midway during the procedure. And so it creates challenges if the counts aren't accurately updated. And so, like I said, counts I think are necessary, but they're not sufficient for preventing retained foreign objects. But in terms of the recommendations, those will I'll need a couple years to complete the research before I make some suggestions.
Thank you. The next question relates to maternal births. Even if there is racial bias, why would this affect the choice of delivery method and the type of anesthetic used?
Why would racial biases impact the choice of delivery methods in anesthetic use?
Right.
So what the research suggests, so cesarean deliveries are associated with higher rates of morbidity. And so there is a movement in the US and actually across the world to reduce cesarean deliveries, particularly for patients' first birth. And so the bias comes into play in terms of how long, for example, you will allow a patient to undergo a trial of labor. And there is evidence that some patients are allowed to labor longer than others. And then there's evidence around kind of cesareans might be the result of physicians' scheduling preferences more than medical necessity. And so the idea is that if we can reduce cesarean deliveries that are not medically necessary, we should. And implicit bias impacts that choice. And then similarly in the work that I just presented, and I work with this division chief of obstetric anesthesia at the hospital. Epidurals are considered, at least at the hospital, the gold standard for cesarean deliveries. And so if there is kind of evidence that Black women continue to receive general anesthesia, which is associated with more adverse outcomes than epidurals, and it's the result of implicit bias, I think it is something that needs to be determined and corrected, because it does have impact on morbidity. And the thought is that the threshold, for example, for cesarean delivery for Black patients is lower.
Next question is from Jim McIntosh. Do you think it could be possible that artificial intelligence could track foreign objects in the OR or in the patient's cavity?
Yes, I think when you say track, I'm curious if you mean in real time, but part of what, because there is kind of technologies in RFID, for example, that's meant to specifically keep track of instruments and sponges that are placed in the patient. But in terms of kind of the work that I'm proposing, where our plan is to use machine learning algorithms to support object detection, for example, during a call for intraoperative radiology. But I do think there are currently existing technologies that attempt to track instruments in real time using RFID.
Thank you. The next question, what key additions did you make to your systems design approach in order to be able to take disparities into account?
So I think the biggest addition, and kind of one of the general recommendations for when you want to look at disparities is linking whatever data, the process or outcome data, to the demographic data, and then disaggregating that data by race, ethnicity, whatever demographic factor you're interested in, to try to identify whether or not differences exist. The challenge, as I mentioned, sometimes you don't have enough outcome data to assess statistical significance. But if, let's say you have 20 falls, for example, which was, not unlike the numbers that I saw in my experiment. If you have 20 falls and 16 of those falls are for Hispanic patients, then my hope is that you wouldn't need to have a p-value of 0.005 or 0.05 to kind of recognize that this is probably worth further investigation. So the linking and disaggregation of data by the demographic factors, I think, is key to applying that equity lens.
Thank you. There was a question posted in the chat. Earlier on in your presentation, you talked about equity. So the question is, here in Canada, would you substitute Aboriginals for people of color?
I don't necessarily think I would substitute Indigenous for people of color. I think one of the things that I'm learning is that Canada talks about race in a way that's different than in the US, right? We use people of color to essentially include all non-white people, essentially. And in Canada, Indigenous populations are kind of considered distinct, right? And so there's this idea of, Black and other kind of people of color potentially making up a group, and then Indigenous not necessarily falling under that group. So I wouldn't necessarily substitute them, but they are two distinct groups that might need to be where the challenges and equity challenges might need to be examined potentially separately.
And now, because of your schedule, I'm going to pose the last question. With Black women avoiding hospitals during pregnancy because of what was stated in your presentation, how then does the healthcare industry fix this and begin to help Black and Hispanic women?
So I'm not sure what you're referring to when you say avoiding the health system, but I think you make a point in that in general there are issues around access and mistrust in the healthcare institutions that's well warranted given the history, given the history of abuse and mistreatment, and particularly even at the hospital where I worked. And so I think part of what healthcare institutions are going to need to kind of come to grips and come to terms with is how to remediate some of the harms that were caused in the community to improve trust. In terms of access, obviously there are huge insurance implications in comparison between the US and Canada, but the main idea of the report, the unequal treatment report, as well as a lot of kind of the health equity research is that hospitals and healthcare institutions can't necessarily wash their hands of these issues. And so that includes kind of short-term efforts to improve, to track and improve equity, but also longer-term efforts that they're going to need to undertake to regain and rebuild trust with the communities that they serve.
Thank you. At this point, I'm going to turn it back to my colleague, Sierra Lamonaco, for her closing remarks.
I just want to say thank you, Professor, for being here with us today. I mean, your presentation was extremely thought-provoking, eye-opening, meaningful. You didn't just talk about human factors engineering and healthcare, but your work is so important on looking how to integrate equity and patient safety, and how your work is looking to improve and honestly just reduce those rates of racial and ethnic maternal health disparities. So just thank you for joining us. I know you have to run to your class, but what an insightful presentation. You're doing some amazing work. So I just also want to say, as I mentioned at the beginning of today's session, today is the day when we celebrate women's achievements and increase visibility. So big round of applause virtually for Professor Myrtede Alfred. You know what? It's just, you're doing amazing work and we appreciate it. And when we look at the last 10 years, we've been seeing a growing presence of women in engineering at U of T. U of T is one of the largest percentages of women enrolled in the engineering discipline across Ontario. However, like the research has highlighted, we still have ways to go to help advance equity, diversity, and inclusion. But that being said, I want to thank Lori for emceeing and chairing today, but also to thank all of you for joining us here. We invite you to share your feedback on the School Lunch and Learn series. A link will be dropped below, and it's now available in the chat and will be shared with you after the event. So share your thoughts, share your opinions. And also, please keep in mind a link to the presentation is going to be shared with all registered guests earlier next week. So please mark your calendars because, as you know, School Lunch and Learn is traditionally hosted on the second Wednesday of every month. However, next month it will be hosted on April 5th, and we'll be hosting a School Lunch and Learn After Dark series. So it's an in-person event featuring Professor Sean Hum. So more details about that in-person event will be shared with all of you soon. So that being said, in closing, I want to thank all of you again for joining us, and I hereby adjourn today's session of School Lunch and Learn. Once again, happy International Women's Day and all the best.
Hear, hear.
Hear, hear. Bye, everyone. Enjoy your day.